Hi guys, I'm Shay. I'm a flight nurse and a paramedic, and today I'm going to talk to you about something they don't really teach in school. It's how to talk to terrified families. Now, I'm going to do this in the lens of helicopter EMS because that's the job that I currently work in, but this applies to really any situation in EMS where you deal with a patient and a family member. Now, when you go to flight school, which we sometimes call ground school, you have this time on orientation where you learn lots of new medical concepts: ventilation, airway management, trauma, invasive skills, EKGs, and then an introduction to all things aviation. But you don't really get a script on how to talk to terrified families. And we have to remember that they are also reacting to one of the most traumatic days of their life as well. Now, this doesn't diminish how traumatic it is for the patient, but that looks a little bit different how we communicate with them than with the family. Now, for most patients that are awake, they're basically getting a play by play of what's happening and how I'm communicating with my partner. And I will typically explain everything that we're doing while we're doing it to them. But today we're going to talk about families. And the first we need to acknowledge is that not every single family member is treated the same. Some families are so overwhelmed that they can't process any information. And some families are waiting for you to come give them an update because they need information to be able to know what's going on and not be as anxious. But from that, I would say one of the most important things is that they don't necessarily need every single detail. One thing that we have to think about is that memory during a traumatic event is a lot of times emotional and not factual. When a person is under intense stress, the brain just does not store detailed information well. So if I try and cram a bunch of medical information into their head, they're almost going to be overwhelmed by it, especially if they're not a medical personnel themselves. And so what's best is to be direct, but to simplify the information for them in a way that they can process it. During this time, the family is likely asking themselves, is my family member dying? Are they in pain? Are you trustworthy? One way that they tell if you're trustworthy is how you conduct yourself on scene. Are you calm? Do you speak calmly and respectfully to your partner and to the people that you're working with around you? Do you exude confidence? When you walk in the room, is there this air of like relief? Somebody that knows what's going on is here and they are managing the situation well. And even though I may not be a medical person and know what's going on, I can tell that they know. And that can bring immense calm to a family. Body language is huge. How we communicate with a family can vary depending on if we're on a scene call or doing an IFT. Now, a lot of times scene calls are rapid. They can be chaotic depending on what's going on around you. And there isn't often a lot of times to talk to family members. The communication has to be quick and direct. They need to probably have an update. And this is a part where you can be reassuring without giving false hope. If the patient's critical, say it. If your family member is in very critical condition, we will do everything we can in flight. And then they need to know where the patient is going. And it can be helpful to collect contact information. At our facility, we try and follow up with the families after the flight. So I'll try and get a name and a number of somebody to follow up with. I'll give you an example why this can be so important though. I had a younger patient who was hit by a train. As you can imagine, his chances of survival were very slim. It was a chaotic scene, and family and friends were accumulating rapidly behind the ambulance. Now, when that happens, sometimes that can almost cause a bit of scene safety issue for the helicopter because we don't want people running towards a helicopter that has an open tail blade spinning. So a lot of times we'll get PDR fire to come try and regulate the scene for us. This family was very distraught, rightfully so. We go open up the back of the ambulance. A crowd starts coming in. First thing I say is, everybody, you need to just please step back. We need to be very careful with the patient, right? And this is actually a really important thing that you can do is in a big crowd of people, ask them, please designate one person. And a lot of times they will look to the person that is most closely tied to the patient and push them forward. And that's what happened. And I said, I want to give you an update. I want to tell you that this is very, very serious. Things are critical and we're going to move very fast to get him to the trauma center. Not false hope, but let him know we're doing everything we can. And I said, please take a second to say goodbye, because I knew that it was probably going to be the last time that they ever saw him alive, and it was. And I don't think that 5 seconds necessarily determined him surviving or not, but that was 5 seconds that the family got to have a proper goodbye with the patient. So that's a place where you have to use clinical judgment. Do I think that that family in that situation could have handled a lot of information? Absolutely not. But did they deserve a chance to say goodbye and be reassured that we're going to do everything we can and have an update? Absolutely. We have to remember that feeling included restores a sense of control. As much as they can see or be updated on, especially if there is a poor outcome, can help process grief or even regret. What they really want to know is that we did all we could. We have to think that uncertainty is one of the biggest factors of anxiety. And that family is likely waiting outside the ambulance or outside the room, craving information from us. So we want to give what we can realistically. Some other examples of when I involve family would be a pediatric patient. So if I have a pediatric patient in the ambulance, we're going to stabilize first because we need all the room to work. But as soon as it's practical, I ask to bring a parent right inside the ambulance. I want them to see what we have going on. I want them to be able to see their kid, especially if their kid is awake. Their kid's probably going to be looking for their parent for comfort anyways. Even if it's as simple as I can open the side door of the ambulance to allow them to see a little bit of what we're doing. There's always the balance of, do we leave all the doors open and everyone's kind of just like watching like a spectator? Or do we or can we open the door and maybe let the family see what's going on? Again, that's discretionary. If you have a parent that is completely freaking out and distraught, that's probably not a good idea. But if they're calm and they want to be present for their kid, I'd like to involve the parents as much as I can. I would say remember that we are not just transporting a patient. We are shaping how a family member remembers one of the worst days of their life. So kindness, compassion, that's what they're going to remember more than every single little medical detail that you tell them. And it has been shown that appropriate communication, offering options when feasible, including them in care can oftentimes lead to better psychological outcomes. The treatment and safety of the patient always comes first. But a lot of times we're treating more than the patient. We're treating the patient and we're treating the family that is present and cares deeply for their loved one. So some things to keep in mind. We always want to deliver good care, but we also want to deliver compassionate care. I do have one more thought I'd like to share because I think it's really important. This person's loved one has now been broken in some way, medically or physically by trauma. And we come to treat them and we have all these lines and wires coming off of them or tubes coming out of them. And then we represent them to the family. And they can sometimes be afraid to touch the patient, or they're afraid that touching them might mess something up with our equipment. It's almost like this delineation where now that we've assumed care, their family member is a patient instead of just their loved one. And we need to sometimes re-invite them to touch the patient, tell them it's okay. I see this a lot with children who are very, very sick or post-code. I flew a sweet, precious child post-drowning, post-cardiac arrest. And the mama flew with us and she was very somnolent. And she, the way our helicopter configuration was at the time, she sat aft facing. So she was pretty much sitting right next to where his head was. And I could see her just looking at him sweetly. And I said, hey, it's okay if you want to touch him or hold his hand. And it was that invitation that she needed to know that it was okay to touch our stuff and to touch him and know that she wasn't going to mess something up. So don't be afraid to re-invite the family to touch the patient and to give them comfort and to reconnect with them. So as a wrap up, a calm clinician is one who speaks slowly, makes eye contact, use their name if possible, and acknowledge their fears. All right, guys, thanks for watching and look out for another episode. I might do a couple more of these, what they don't teach you in flight school. Just some random things that you don't think of until you actually start doing the job. Anyways, thanks for watching. Don't forget to like and subscribe, and I'll see you next time. Bye.